Good afternoon, everybody. I think what I have thought was that we will do this basically learning through cases. So, this is the thing. So, instead of reading the book, what we will do is we will see some cases, and through those cases I think we will try to catch the points. So, before I do that, I wanted to tell you that I wanted to bring to your notice how any doctor or any clinician or we make decisions in our OPDs. So, I think that part I wanted to tell you. So, there is something called recognition primed decision making, or RPD in short, recognition primed decision making. So, what is this recognition primed decision making? There is a dual theory of cognition. So, whenever we learn something, it is by two processes, and the first process is where we think is intuitive thinking. So, if you have to take a decision, you intuitively make a decision or you do analytical thinking. So, what is this intuitive thinking? Intuitive thinking is something like artificial intelligence or like machine learning, or you can say the data sciences, where you see a set of data and based on the pattern you fit that pattern into the already memory you have of that particular disease. So, for example, if you think of tuberculosis, you might think that okay, the person complains of cough, complains of expectoration and complains of blood hemopsis. So, anybody who has got this constellation of things, fever, cough, expectoration, hemopsis, then you start thinking that okay, looks like tuberculosis is the first possibility. 4 or 5 things you see and you fit it into a pattern, and based on that pattern you can make the diagnosis. So, this is called the intuitive thinking. But there is another kind of thinking when the data does not fit. So, you have some data, you have cough, hemopsis and you have the thing, and but you do not have fever. So, now you have something which is missing, or instead of that, let us say you have history of taking some drug or something, and then you start thinking that what is the problem? It is not fitting completely into tuberculosis, and it could be because of somebody has consumed some oral anticoagulant and can come with the same kind of thing. Hemopsis can be because of that also. So, then thing does not fit. So, you start thinking why that particular thing is not fitting, and you start finding new things and trying to think what could be the reason why this is not fitting into a pattern. So, that kind of thinking is called analytical thinking. Majority of clinicians, experienced clinicians, what they do is this kind of thinking. So, we know that by experience, we have this thinking that the more experienced the physician is better, because what has happened is that physician has developed a library of cases in the mind, and then whenever new case comes, the physician tries to match it with the library that is already available, and if it fits, then he can directly make the diagnosis. So, the experienced physicians have a library of cases in their memory bank, and through that they can do, and obviously as you can understand, because if the pattern fits, then you do not have to step by step think it, you do not have to analyze, you directly make a decision. So, it is faster and many times even more accurate, because the mind has a data bank, and the new problem that you see, you fit with that particular data bank, and if it fits, then you make the diagnosis. So, I think this is very important to understand, but at a student level, it is likely that you do not have that library of cases or that particular case bank, and that is why it takes some time to make a decision. You have to go step by step, and then you make a decision. Over time also you will build a library. So, one of the advantages, as you can see, of having these case reports or case series is that even if you do not have experienced that case yourself, you can live that case, and then you can build your own library, and then that particular library will serve as module for the subsequent next case you see, you try to see how many things fit in the original case that you saw, and then based on that, if everything fits, then you will make the diagnosis. If something does not fit, then that part you will analyze, why it is not fitting, what could be the possibility, what are the other things, and so on and so forth. So, but 2 cases you do, and then both of them same diagnosis, then the third case comes, you can fit into these 2 cases. So, this is how human mind works. I thought I will sort of put it before you, so that you understand what we are doing here for you. So, now coming to heart failure, that heart failure, now the prevalence is said to be about 1 to 2% in adults, and the prevalence is increasing. So, this is something that is going to increase over a period of time. Heart failure is increasing and it is reaching epidemic proportion. Why is it that happening? Because heart failure happens is basically degenerative heart disease leads to heart failure also. So, it is related to age. So, as the population ages, if in 1900s the average lifespan for any human being was about 30-35 years, and now once you reach about 2000s, the lifespan has increased, average lifespan has increased to about 75-80 years. So, it has practically more than doubled. So, you have now aged population, and that is why you see certain diseases more common now than previously. And what are those diseases? Of course, heart diseases, even more importantly heart failure, because it is a age related phenomena, but also other diseases like cancer. Previously there was not enough time to develop cancer, now cancer can take time and you find more cases of cancer. Stroke is another thing which has happened now, because it is age related. What things happen with age, what diseases start with age? For example, blood pressure, hypertension. Younger ages it is practically absent, there could be secondary cause for hypertension, but primary hypertension is generally not there. But as we keep aging, then blood pressure problem increases. Another cardiac problem that is age related is atrial fibrillation. So, if you look younger age, very low chance of AF, but as the age increases beyond 50 years, beyond 60 years, beyond 70 years, it is said that if you live the whole thing, then about 50% of people will develop AF even without any cause. So, this is another age related problem. Likewise, heart failure is a kind of age related problem. One is because of age, but the other important thing that you have to understand is that because of a treatment has improved so much, that we are able to save life in many cases of heart attacks or myocardial infarctions. So, once you save life, so life is saved, but heart damage has already occurred. So, LVF or LV dysfunction has set in. So, it is a precursor for developing heart failure. So, that is why, because we are saving so many heart attack patients, that we have this increased incidence of heart failure also. So, that is another reason why heart failure is increasing over a period of time. But once heart failure happens, then you have to understand that it is a progression. So, it cannot more or less reverse back, there can be some remodeling and there could be some reversal, but practically the disease is progressive. So, what happens is, once the disease progresses, then there is a possibility that there could be a decompensation also. So, advanced decompensated heart failure also starts increasing after a certain age. So, after 55 years of age, the incidence of advanced decompensated heart failure becomes 1%, and requiring recurrent hospitalization in 7 out of 1000 people, 0.7% require hospitalization. So, now you can see. Now, the third important thing about heart failure is that lot of advances have happened in therapy. So, for example, first of all in diagnosis, some major advances have been made in diagnosis of heart failure. What are those advances? One is the biomarkers, especially the brain natriuretic peptide or pro-BNP. So, that is something that has happened, and that is an important step in diagnosis of heart failure. The other thing that has come up is in the etiology of heart failure, there is now MRI, which is significantly contributing to diagnosing heart failure conditions where other causes can be excluded. So, most common cause is of course ischemic heart failure, but if ischemia is ruled out and then somebody is having, then structural heart disease can cause, like valvular heart disease can cause heart failure. But if everything is ruled out, then I think the only tool that can pick up the cause of heart failure could be MRI. So, this is another advance that has happened in the diagnosis of heart failure. Then in treatment of heart failure, lot of advances have happened, and what now we have is, we one by one discovered drugs that improve mortality in heart failure. So, the first drug to be discovered to improve mortality in heart failure was probably ACE inhibitor, and then ARBs. Then very paradoxical thing was found, that people initially thought that beta blockers are contraindicated in heart failure, and if you want to kill somebody with heart failure, you give beta blocker and you could probably kill a person by giving beta blockers. But now what has happened is that more and more evidence has come that beta blocker usage in heart failure, of course very careful usage of course, and very gradual use or guided use of beta blocker, but if you do that, then it has been known to reduce mortality. So, the drugs that can improve mortality in heart failure could be ACE inhibitor, ARBs, beta blockers, and then later on it was found that in some types of heart failure, even mineralocorticoid receptor antagonists like spironolactone or eplerenone can also improve mortality. So, these 2-3 drugs have become first line therapy, and using especially at least 1 or 2, then recently you might have also heard better than ACE inhibitor or ARB is now something called ARNI. So, that ARNI has got some benefit over and above the use of ACE inhibitor or ARBs. So, ARNI has also come up. So, basically there have been lot of advances in heart failure therapy, and we now have drugs which are reducing mortality and therefore become first line drugs, and ARNI is among them. Recently, some more drugs have come up, and which is the recent drug that has come up? Anybody? SGLT2 inhibitors. So, now this is very interesting, because initially people thought that SGLT2 receptors were, let first the medicine people speak, then cardiology people. Okay. So, we know that SGLT2 receptor antagonists are basically anti-diabetic drugs or anti-glycemic drugs, but what has the recent data has come is that these are some of the drugs that can prevent development of heart failure, but more importantly can improve even mortality in heart failure. So, these are some of the new drugs that have come up and that have improved I think significantly the treatment, and the basically coordinated use of these drugs in a stepwise manner and in a proper manner is called as GDMT. What is GDMT? So, again I know cardiologists know, I want the medicine people to think and tell. So, it is guideline directed medical therapy, and people have found that if you follow guideline directed medical therapy, then there could be improvement in mortality. So, this is improvement in drug treatment. There has also been improvement in device treatment, and people have found that certain cases of heart failure, some devices can help. For example, ICD can be of use. What can ICD do? Because what happens is, arrhythmias are one of the common cause. In heart failure, the two most important cause of death are, one is progressive heart failure and the second is arrhythmia. And about equal amount people die because of progressive heart failure and arrhythmia. So, if you use anti-arrhythmic agents, that is why beta blocker is helpful, and that is how this ICD, what is ICD? Cardioverter defibrillator. So, that can also prevent at least mortality, improve life of heart failure patient by preventing death, because it gives shock at the right time. But other than that also some other devices have also been found useful, and what is that device? Anybody? Cardiologist? No, before left ventricular assist device. CRT. What is CRT? Resynchronization. So, CRT is another device that has been found useful in some cases of heart failure, especially with broad QRS. So, left ventral branch block, and there are many other parameters also that you can see whether CRT can be useful, but simple thing to remember is when there is LBB with heart failure, then CRT device may be of use. So, this is device therapy. And then now there has been improvement in even surgery. And what is the improvement in surgery? One is that ventricular assist device, that now you have ventricular assist devices which can bridge till transplantation can be done, or now there are some destination ventricular assist device also which can for a long time provide relief even if transplantation is not possible or cannot happen. These ventricular assist devices have also come. So, you can see that there has been improvement in practically every aspect of heart failure, from diagnosis to drug therapy to device therapy to surgery. But the interesting part is that mortality has practically remained same. Despite all these advances, the mortality has been remained practically same, about 10% at 1 month, about 30% 1 year, and about 42% or about half die within 5 years, which is worse prognosis than many types of cancer. So, heart failure is something where the mortality has not declined, and why is that despite all these things available? Why? Because sicker myocardial infarction patients are surviving because of therapy. So, now previously sick myocardial infarction patients could die, but now we are able to save them. So, they are saved, life is saved, but ejection fraction is so low that they have so many complications. So, despite the fact that some heart failure patients are benefiting, the new heart failure patients are coming which are very sick, and therefore, the overall mortality has not been affected. Now, if you look at heart failure, there is another very revolutionary kind of understanding that not all cases of heart failure are with reduced ejection fraction. So, that is something called HF, reduced ejection fraction, heart failure with reduced ejection fraction. Nearly equal number of patients are heart failure with preserved ejection fraction, and we will, I think during this course of cases we will come through to those cases as well with preserved ejection fraction which still have heart failure. So, and the number is nearly 50 equal. So, that is the interesting part, because people thought that it was only reduced ejection, and now there is another group and there is some controversy which is called in between ejection fraction, between let us say 40% to 50% ejection fraction. So, that group has added, sometimes they add, sometimes remove, but there is another group. So, anyway, let us leave that aside. Now, coming to heart failure, why do we want to see these cases of heart failure? What is this learning by cases important for heart failure cases? Yes, it is. Why? Because heart failure is not one homogeneous entity. It has got several etiological components, it has got various pathophysiologies, it has got various clinical effects, and then different treatments also. So, there is a complex interplay between all these things, the diagnostic part, the etiology part, the pathophysiology part, and the treatment part. So, that you cannot read from textbook. So, that thing, I think from case you can understand how these things evolve. So, that is one. The other thing is that heart failure, if you will see in life, it's a temporal thing. So, you may find a heart failure with normal ejection fraction, so to say, and then you may find low LV dysfunction, but no heart failure. Then later on you may find heart failure with LV dysfunction, and then you may have acute decompensated heart failure, and all that happens over a period of time. So, that temporal profile you cannot see by textbooks, because textbooks will not teach you that how the temporal thing is happening. So, all those kind of finer things you can appreciate if you see the cases. So, what I am going to do, friends, is in this series I will discuss 9 cases which will bring these complex interrelationships between the different aspects of heart failure. And what I will do is, I will do this intelligent data analysis in front of you, although I could do some of the things intuitively, but for you I will do this intelligent data analysis or analytical thinking, so that it goes into your memory bank, and later on it can become part of your intuitive thinking. During this course I will ask critical questions, I will bring out all the dilemmas I faced, and then I will discuss what mistake we committed, and then I will keep reinforcing cases learning that we see from all the individual cases. I believe Dr. Mahidhar was there in a few of those cases which I will discuss, and but a few of them are also from past and other cases. So anyway, so what the cases that I am going to discuss with you will be, first will be acute decompensated heart failure, second will be guideline directed medical therapy, third will be to identify the cause, fourth will be differential diagnosis of cardiomyopathy. How do you make a differential diagnosis of cardiomyopathy, because that is one of the important causes of heart failure. Then I will start talking of some of the complications of treatment. Hyponatremia is one of them. Then also I will talk of some of the complications happening with the devices, for example CRTD. Then after that I will shift gear and move to diastolic dysfunction, talk about heart failure with preserved ejection fraction. Then I will talk of one type of diastolic heart failure, that is high output failure. And then finally I will end up with one of the most serious complications with heart failure, that is cardiorenal syndrome. So I will see how much I can cover. Maybe I will take some time. Every day I will have something interesting to discuss. And Dr. Mahidhar, you want to add something on the heart failure thing, anything? Maybe I will go to this first slide and maybe you want to say something.
Mid-range ejection fraction and recrudescent heart failure has recently been common, and after SGLT2 inhibitor, the newer thing is Vericiguat, which is recently come in Victoria trial. These two are the latest things which have come.
So just say loudly, because I think people can't understand.
After the SGLT2, the first drug which we had after the SGLT2, recently it has been given in the ESC guidelines. It's the Vericiguat, which has been evaluated in the Victoria trial. And in the heart failure with reduced ejection fraction, preserved ejection fraction are there. Between 41 to 50, another they just brought a heart failure with the mid-range ejection fraction.
Yeah, that is what I told. Yeah, mid-range ejection fraction.
Heart failure with reduced ejection fraction, those patients actually come into heart failure with mid-range ejection fraction, or they reach up to 50%. Those patients actually are called as heart failure with recovered ejection fraction. And once heart failure with recovered ejection fraction comes, some physicians actually they tend to downgrade the medications which they were receiving previously. And it has been found that in around some 47% of those cases, they actually go subacutely into again heart failure with reduced ejection fraction. This is called as actually heart failure with recrudescent heart failure basically. So there has been trial also which has gone. I don't exactly remember, it's trend heart failure or something which has recently come in this year only. It showed that you should not be downgrading the medications of the heart failure, even though the heart patients have improved with ARNIs and other medications which we have started.
So I think very important point he brought to notice, that when we treat heart failure with these drugs, some of them, because basically they improve ejection fraction. So ejection fraction can become practically normal. And then you have a feeling that patient is recovered, and like antihypertensives also, if you give antihypertensive, blood pressure will get controlled. Person will think I have recovered and stop the antihypertensive, and the blood pressure will again come. Likewise, the same thing is happening, that if you stop medication in somebody who is recovered heart failure, then person can have another recurrence of heart failure. So I think it is important to understand from clinical point of view, and also to give a message to the patients, because patients often think that they have recovered and then they don't want anything else. So I think it's an important point.
They had shown majority of the drugs were discontinued by the treating physicians rather than
Yeah, because physicians feel that now it is recovered, so we don't need those drugs, and they stop it themselves. Yeah. So I think very important point. So we don't have to stop the medications of heart failure. It's like, you can get on a tiger, but you cannot get off it. So once you are on the drug, then probably you continue. Anyway, so thank you so much. And now let me come to the first case, which is the benchmark case. Is there any pediatrician here or no? Some pediatrician. So this is a 15-year-old girl, and she presented with dyspnea on exertion class 3, which was happened within 3 weeks, and from 3 she went to class 4. So recent onset dyspnea, class 3 to class 4, no history of fever, no history of chest pain, and vitals showed blood pressure of 90/60 and pulse pressure of 30. Heart rate is 104 per minute, respiratory rate 24 per minute, and oxygen saturation 92% at room air. So, what do you make out? What information you got with this just case? No, not bradycardia, 104 per minute. Pulse pressure is 30. So, you understand what is meant by pulse pressure 30? You understand what it means? The difference is less. Were you there in the yesterday's class? You were there? And you were there in the cardiogenic shock class I took, where I talked about pulse pressure? No, you were not there. So, any medicine person, will you tell us what it means if you have a pulse pressure of 30? What it means? Dr. Kitesh, you were also not there in the class. If the pulse pressure is, see, when pulse pressure is 30, it means systolic is not high, right? Diastolic is also, but diastolic is pretty high comparatively. So, that means systemic vascular resistance is very high. When that happens? Kind of. So, basically there is a hemodynamic compromise, early hemodynamic compromise, if you can call, practically a hemodynamic compromise, because already 90. So, if you have a narrow pulse pressure, you start thinking of heart failure. That is one possibility. Any other possibility? Dr. Mahidhar, anything else? Yeah, but because of what?
Redistribution due to failure.
Yeah, so basically heart failure is a very strong possibility when you have this narrow pulse pressure.
Blood loss, blood loss or volume loss also.
Also volume loss. So, if there is a lot of volume loss, bleeding, etc., less blood volume, then body does not have, there is not enough ventricular filling, so it cannot generate the systolic pressure. But what it can do is, it can increase the peripheral vascular resistance and take up the diastolic pressure, so that the attempt is to maintain the cerebral perfusion by mean blood pressure. So, what is that critical mean blood pressure that we want to maintain? So, what is the mean blood pressure here in this patient? Medicine people first. Anybody? No? 70. So, the body is, there is some hemodynamic problem, but body is trying to cover up so that mean blood pressure remains above 65. So, that is what is happening. So, that is the reason why diastolic blood pressure starts rising. Also proven by tachycardia, which means that not only heart is trying to increase the stroke volume, but it is also trying to increase the heart rate and therefore maintain the cardiac output. So, heart is trying level best to maintain the cardiac output. So, there is something which is preventing that cardiac output, and heart is trying its level best. And also, you know, ultimately it is oxygenation and it is not just plain perfusion. So, oxygen also, tachypnea also to try to maintain the oxygen at a higher level, so that perfusion or oxygenation is okay. The other reason could be, there could be, why there can be lot of tachypnea in this kind of situation. Any guesses? Any guesses? Yeah, very good. Who is that person? Very good, very good. So, it could be that this pressure is low, 90, we have not auscultated the chest as yet. Could be patient is getting into pulmonary edema kind of situation, and that is why there is so much tachypnea. So, everything is kind of fitting, and also you can see saturation is also bit down. So, maybe, you know. So, anyway, what we can say is that this is an adolescent girl with history of progressive dyspnea of recent origin without any history of fever, and with developing hypotension, some hypotension and some hypoxemia. So, obviously, we can see that this girl is in trouble, because very young girl, 15 years, she is not expected to behave like this. So, we have to do something about her, right? Just looking at the patients, let us look at the symptoms. So, the predominant symptom is dyspnea. So, what are the causes of dyspnea? In young, let us say, so of course, asthma is one cause, that is possible. Heart failure, as I said, already discussed with you, is most likely cause, but there could be other problems. Pneumonia, but less likely. Why less likely? Because no history of fever. It can happen without fever, but unlikely. Bronchiolitis can also happen, but generally bronchiolitis happens at a much younger age. I think pediatrics, when does the bronchiolitis happen? Pediatric people? So they don't say, but anyway, so basically generally it occurs at a very young age, less than 2 years. Anemia is possible, because anemia can also cause dyspnea, but problem is, can anemia cause this kind of picture? Number one, it has to be very, very severe anemia to cause this much dyspnea. Number two, anemia will cause fluid overload. So anemia will cause fluid overload, not hypotension. It will not present commonly as a hypotension. So that is again less possibility. Pulse pressure is also very narrow. So that is the second thing. So yeah, the anemia will have bounding pulses. Here pulse pressure is narrow. It will be very weak pulse. Pulmonary thromboembolism also a possibility. We are talking of all the possibilities of dyspnea, but there is no pleuritic chest pain, as you can see. No other evidence of, normally at least 50% you will find evidence of DVT also, but there is no evidence of DVT, etc. So unlikely. And finally it could be psychogenic, but psychogenic breathlessness will not cause this kind of hypotension. So obviously it is quite out. Now, so looking at vitals, we see that there is evidence of shock, and with narrow pulse pressure, tachypnea and slight hypoxemia. So basically it seems like a primary cardiac failure. So cardiac disease seems to be out of proportion to any lung disease if present also, if at all present, but cardiac disease seems to be out of proportion. So it looks like a predominant cardiac failure. Anemia can be associated or added, but it cannot lead to this kind of picture. So basically what we have is, we have a case of looks like heart failure, but we have to rule out some things. We might want to rule out a pulmonary thromboembolism, which can happen in association with heart failure. We have to rule out anemia, which can happen in presence of heart failure also. So now let us come to the examination. So now you can see, just based on history, we have not even examined the patient. We just saw the history, and based on history itself, we can make a very good diagnosis. Now in the cardiovascular system examination, S1 normal, S2 normal, S3 is present, but there is no murmur, auscultated, chest, bilateral capitations. So, so what do you see? So presence of S3 confirms that there is a heart failure, or at least left ventricular failure, or maybe even right ventricular failure, but since LVS3 is there, so it is a left ventricular failure most likely. Bilateral creps suggest that patient could be in pulmonary edema. Pulmonary etiology, can be possible, but is unlikely, because there is not, if it was predominant pulmonary problem, I think important thing that you need to understand is that if it was predominant pulmonary problem that was leading to heart involvement, that is hemodynamic compromise, then saturation should be very low. It cannot be 92% saturation without oxygen. So it looks like primary cardiac problem, but with maybe involvement of pulmonary, or may not be involvement of pulmonary, but primary cardiac problem. At least the main problem is cardiac. So okay with that? Any discussion? Then otherwise there is no other problem that looks like. The fine creps could be matter of heart failure, and also if it is a long standing lung disease, then second heart sound should be increased. So that has not happened. So looks like we are more or less safe with diagnosis of heart failure. Now let us see what are the causes of heart failure in adolescents. So of course number one cause, mostly at least in Indian setting, is at this age maybe must be valve diseases, and but there is no murmur, and however we have to say that sometimes the murmurs cannot be auscultated that well, they might hear, but broadly there is no murmur. If it is not valve disease, then the problem could be primary myocardial, which could be either dilated cardiomyopathy or myocarditis. So, which one is likely between the two, whether it is myocarditis or cardiomyopathy? Now, if it is a dilated cardiomyopathy of non-myocarditis origin, then the main thing is that the onset is not so rapid. The fact that it has happened in within 3 weeks makes dilated cardiomyopathy rather unlikely. Ischemic is common, but obviously this age is not of ischemic cardiomyopathy, so ischemic is already out. But then other types can be present, drug induced, but there is no evidence of any drug intake, rhythm disturbances, but there is no rhythm disturbance so far as we know, only some sinus tachycardia, no muscle dystrophy, etc. So, I think between the two we are quite okay with myocarditis. The only problem is that there is no fever, but 50% of myocarditis may present without fever. So, it is not necessary that myocarditis should have fever, although if fever was present, then we would be more secure with diagnosis of myocarditis. Coming to congenital heart disease, again I think the point is that within 3 weeks it has happened, and there is no murmur, there is no other thing that suggests congenital heart disease so far. So, that is also unlikely. Likewise, restrictive heart disease, such rapid onset does not happen with restrictive heart disease. So, I think what we are having at the moment is either myocarditis or dilated cardiomyopathy, most likely myocarditis, because dilated cardiomyopathy will not present so rapidly. So, the differential diagnosis so far, as I said, pericardial disease is also very unlikely. Why? Remember, if there is S3 present and if there is evidence of left sided failure, then pericardial disease becomes very unlikely. So, with pericardial disease, third heart sound is very uncommon. So, if you see third heart sound, it practically rules out pericardial disease. Pericardial tamponade, again there is some hypotension with some narrow pulse pressure, which also happens with pericardial tamponade, but again S3, you will not get S3. So, you see every sign is very important, because that helps you either make or break a diagnosis. So, if you are getting S3, then you rule out practically or significant pericardial disease. There can be some associated disease, but significant pericardial disease or prime pericardial disease is ruled out. So, I think that is very important. Then constrictive pericarditis is also the same thing, as I said, that presence of S3, left sided failure, shock, very unlikely with constrictive pericarditis. Shock can happen with pericardial tamponade, but S3 is not likely. Then HOCM is another possibility, but again rapid progression rules it out. Severe anemia I already talked about. Severe anemia can cause some dyspnea, breathlessness, but cannot cause so much hemodynamic compromise unless like a hemoglobin is 2 or 1 or 3, something like that, which is very rare. So, it cannot cause so much, and then it will cause a wide pulse pressure, not a narrow pulse pressure. So, I think we are quite secure in our diagnosis so far, and we have practically made diagnosis just history and clinical examination, which is heart failure due to most likely myocarditis, right? Now, let us go further, let us look at ECG. So, what do you find with ECG? ECG, I think of course, you can see that there is some tachycardia, which looks like sinus, but I think the most important finding here is a low voltage QRS. So, that is I think the most important finding. And what is the commonest cause for low voltage QRS complexes? Sorry? COPD. So, anything that brings the difference between myocardium and chest wall, because you put ECG leads on chest wall, there is a lot of gap, then of course, the voltage can be low. So, anything that can cause that, for example, excessive air because of emphysema, any fluid there, pericardial effusion, pleural effusion, anything that comes in between of heart and the chest wall will cause fat, even fat or obesity. But other thing is that some types of myocardial disease can lead to low voltage complex on ECG. And what are those myocardial diseases? Anybody? I have written already, but so please understand that there are certain diseases, and more than these few, Dr. Mahidhar will also tell. amyloidosis. That is a very classical thing which can produce low complex ECG, low voltage ECG complex. So, in everything looking normal, patient complaining of breathlessness, maybe you get some right sided findings, and then ECG you see low voltage, then you start thinking of presence of amyloidosis. So, that is another very important cause of low voltage. But other than this, there could be a serious inflammation or infection or infiltration of the heart. Amyloidosis is of course infiltration, but serious inflammation of heart, like for instance myocarditis, can also cause this low voltage ECG. So, everything fitting so far. ECG is also showing sinus tachycardia because of hemodynamic compromise and showing some small complex QRS complexes, probably telling us that it is like very serious kind of myocarditis that has led to so much inflammation that QRS complexes have narrowed down. So, good so far. Any comment, anything from anybody?
So, endocrinological and nutrition also need to be considered in case of this study. Selenium deficiencies.
Yeah, for this kind of thing, but like this kind of rapid progression.
Generally will not occur, but
Yeah.
endocrinological can occur. So, with hypothyroidism or something like that, they may present subacutely basically.
So, they can have something like this. Some atypical cases of endocrinal presentations can happen like this, but so I think in these cases ECG is more important in ruling out than ruling in, because you can't make a diagnosis based on ECG, but you can rule out certain things. For example, you can rule out HOCM for sure, number one. You can rule out some pulmonary embolism also, more or less, although there is some sinus tachycardia, but other findings of pulmonary embolism are not there, especially the classic finding of S1Q3 T3 is not there. Then pericardial disease is also very unlikely. Severe anemia also becomes unlikely because of these very narrow QRS things, and also some other problems that are associated. Normally anemia will present with left ventricular hypertrophy, not narrow complex, low voltage complexes. So, these are the important things. So, ECG practically rules out some of the things, may not make the diagnosis. Now, coming to X-ray, what does this X-ray show? Basically, it shows the presence of cardiomegaly at the moment, and it is not showing too much congestion. But what it can tell you is that there is no pneumonia, there is no pulmonary thromboembolism, there is no pericardial effusion, there is no constrictive pericarditis. So, what we are left with is from our table is probably only dilated cardiomyopathy or myocarditis, because there is some cardiomegaly. So, this is all you can say about X-ray. So, again X-ray will basically rule out some possibility. It will be very difficult to get the diagnosis with X-ray, but you will rule out many things with X-ray. More importantly, you can rule out pneumonia at least. You can say for sure that there is no pneumonitis. Now, coming to lab tests, now as expected there is some anemia, but it is not very severe variety, it is just 9. There is this TLC is increased, as you can see, some neutrophilia. So, we are telling you that there is either some infection or inflammation, something of that sort. Sodium is towards the lower side and potassium is definitely low, 3, which shows you that potassium is quite low and it may be a cause of concern. Urea creatinine, as you can see, is preserved. SGOT-PT is raised. So, there is some elevation of liver enzymes, and we need to find out what could be the reason for these liver enzymes. But if you look at the specific markers, you see that especially BNP is 8270. So, what is the normal value of BNP? Anybody? Normal value of BNP?
Less than 500, 4 to 700. Less than 400 to
Approximately that. So, less than 300 will be like totally normal. 400 to 700 may happen in some cases, but this kind of elevation will certainly put it in favor of heart failure. Clearly, it will put in favor of heart failure. So, see how biomarker is helping. But the other interesting finding is that you find that TSH is 7.73. So, that is interesting. Now, how do you analyze this whole picture? We know that BNP is markedly raised, so very likely to have acute decompensated heart failure. There is some mild anemia. The hypothyroidism is subclinical. What is the value of TSH where you start treating? Medicine people. So, this is in between, it is only 7. So, what can be the reason? So, it is not less than 5, so it is not normal, it is not more than 10, so it is not something which requires treatment. So, it is subclinical hypothyroidism. So, what could be the cause? Anybody? बताओ डॉक्टर महिदर इनको. So this is something which can happen with heart failure. So, you have to keep in mind that this is something that can happen, and it is called as this low T3 syndrome. That can happen and it can cause subclinical hypothyroidism. That can be a part of heart failure, and I think it suggests a poor prognosis generally. Also, there is this mild hepatic dysfunction, which could be because of 2 reasons. So, if it is myocarditis, it could be because of viral hepatitis also, that can also affect the liver, but also it could be because of congestion and hemodynamic compromise that is there. So, perfusion, hepatic perfusion may have been affected, and that can cause this slight elevation of liver enzymes. So, now I think we are pretty clear that heart failure is the most likely diagnosis. So, we just see that the diagnosis we first made in history itself, we are just confirming. We confirmed it with clinical examination, then after X-ray ECG we confirmed, then after the biomarkers also we confirmed the same thing. And obviously, heart failure is more likely because number 1, progressive dyspnea, third heart sound is present, creps are present, cardiomegaly without pulmonary involvement, neutrophilia, raised BNP, and mild hepatic dysfunction, which would be a part of it. And others, I think we can now rule out, especially dilated cardiomyopathy also we can rule out, because there is a rapid progression, that was the main thing, and no other finding that suggests dilated cardiomyopathy. So, but of course, better diagnosis can be obtained by echocardiography, and then echocardiography shows you ejection fraction of 15 to 20%, LV little upper level of normal. So, if ejection fraction is 15, but LV is not dilated, then what is the cause? LV is dilated, but just borderline dilated. What does it tell you? Acute onset, probably of acute origin. MR also is there, but there is no thickening of mitral valve, which again tells you what? No RHD, maybe dilatation of the ventricle, that is contributing to secondary MR. So, it could be because of just dilated left ventricle, which is not dilated too much, but is starting to dilate. Some TR also, and some circumferential pericardial effusion, which is likely with any sick cardiac problem. So, basically what we find is that there is a gross LV systolic dysfunction of recent origin, moderate MR, right sided features are probably because of left sided failure and mild pericardial effusion. Now, how do you clinch the diagnosis? Now, how do you clinch? You think that it is, you clearly know this picture is suggestive of dilated cardiomyopathy, you suspect is of recent origin, but how do you prove that this patient is a case of myocarditis? Anybody? Dallas cardiac, but myocardial biopsy do you recommend? What is the test that you recommend that will confirm your diagnosis now? CRP will tell you cardiac MRI. So, cardiac MRI is, I think, the test that is now being used more and more. As I said, this is newer advance, and MRI will tell you is probably the gold standard, and what it will show you is indication of subepicardial scarring, which suggests myocarditis. So, this is what it is showing, and MRI has now become the gold standard, and this criteria Dr. Mahidar was talking about, Lake Louis criteria, has an accuracy of 70%. MRI is now the the gold standard for diagnosis of myocarditis. It can help in localization and quantification of tissue injury, and this is the MRI picture that is there in this particular patient, suggestive of myocarditis. So, now what is the treatment strategy? Before deciding the treatment strategy, we need to prognosticate the patient, and so what is the prognosis? So, if it is a case of myocarditis leading to dilated cardiomyopathy, leading to heart failure, what kind of myocarditis it is? If it is less than of 1 month duration, then it is called fulminant myocarditis. So, basically it is of less than 1 month duration, 3 weeks only. So, it is a case of fulminant myocarditis. Now, if you look at fulminant myocarditis, the mortality rate is around 50%, up to 50% mortality. So, high mortality, but this patient is even sicker. Why? Because not only fulminant myocarditis, it has already suffered hepatic failure. Already BNP is very high, as you already noticed. Already patient has subclinical hypothyroidism. So, all these things make it that looks like that patient has got fulminant myocarditis, but is even more sicker than what you normally expect. So, how do you treat this patient? So, first is you get a radial line for blood pressure monitoring, because you can expect that this patient will can suddenly deteriorate. Then you put a Sonn-Ganz catheter if possible. If it is in cardiology setup, CCU setup, you put a Sonn-Ganz catheter, try to measure the pulmonary capillary wedge. What is now pulmonary capillary wedge pressure has been replaced by a new term. What is that term? I told last time, pulmonary artery occlusive pressure. So, because this term is a misnomer, you need to, what you are really finding out is pulmonary artery occlusive pressure, PAOP. But anyway, old times say pulmonary capillary wedge pressure. So, pulmonary capillary wedge pressure should be measured, and what is the normal pulmonary capillary wedge pressure?
4 to 12.
4? Huh?
Up to 12.
12. So, you need to keep it below 14. Here it was like 18. So, that is important. This is the goal, that you bring down the wedge pressure to less than 14. Then what we did was IV dobutamine was started, and fluid was restricted, because already looks congested. Pulmonary capillary wedge is so high, so already there is congestion. So, fluid was restricted. Potassium oral dose was given. Diuretic was also started. Although pressure is 90, you have to be very careful. You have to give diuretic, still keep the mean arterial blood pressure above 65. So, diuretic was started. Telmisartan was given. Once starting this dobutamine etc., blood pressure picked up more than 100. At that point, telmisartan was started, and at that point vasodilator was also started, IV NTG was also started, and oxygen was given by mask to keep oxygen saturation around 95%. Do not try to get it to 100%, keep it just 95% or just above 95%. And then immunoglobulin IVIG was given, because it was thought to be a case of myocarditis. Also, there is some controversy, some debate whether IVIG should be given or not given. We gave this IVIG, and IV prednisolone was also given. So, basically this is immunotherapy for massive inflammation. So, it is like anti-inflammatory agents that are given, and immune therapy is given. But problem is that there are several questions in mind, and basically the first question that we ask is, we started dobutamine, but which is this best drug, or which is that best agent to be started in a shock with acute decompensated heart failure, whether it is dopamine, whether it is dobutamine, whether it is adrenaline, noradrenaline, vasopressin, that is number one. Number two is, how do you manage the dyselectrolytemia that we see here, particularly low sodium? So, should we give a sodium supplement by giving oral salt or hypertonic saline, or we do just fluid restriction? And for potassium, do we give potassium supplementation, or we can give certain drugs that are useful in dyselectrolytemia like Vaptans, tolvaptan for example. So, should we give something like that? Third thing that we need to work on is what kind of ventilatory support is required. Should we give just oxygen inhalation by nasal prongs? Should we give non-invasive ventilation, CPAP, BPAP, or full mechanical ventilation? Because we know that patient is very sick, can go into respiratory arrest also. So, should we do any of these things? Then another interesting question is, do we need to give thyroid replacement in this patient? Although normally you won't give, but this is a sick patient. So, can thyroid replacement help here? So, that is another question in mind. Then you see that there is some anemia. So, what do we do for anemia? Should we give oral hematonomics? Should we give erythropoietin? Should we give iron, IV iron, or should we give blood transfusion? So, these are the things, but I think the most worrying is that have we conducted all the investigations? Do we require any further investigation in this particular patient or not? So, any further investigation that we could have done here to guide the therapy or to fine tune the diagnosis? Anybody? Dr. Mahidhar, you remember this case?
No sir, I was not there in 17 with this patient.
Oh, okay, I see.
I think Chancellor and pulmonary myocarditis are a biopsy diagnosis.
So he says that we should have done a biopsy in this particular patient. In fulminant myocarditis, what he is saying is that we should do biopsy. Okay, that is one. Anything else? Should we do serology, looking for type of virus? Because we are thinking of viral myocarditis. So, should we do serology? Anybody? Coxsackie virus causing myocarditis, maybe you can treat? No? Okay. So, I think I will end here. I will say that this particular case shows you that we have more questions than we have answers, because always we are a bit confused what should be done, and this is like typical for cases of heart failure. So, what I will do is today I will end here and I will let you think about this case, and then we will come tomorrow and then we will see how this case goes or some other cases go, and you meanwhile think about it, and then we will have. But at least we have two thoughts that maybe we have not done enough as far as diagnosis is concerned. Maybe we have not done biopsy, that is one, and maybe we have not done these serological tests for let us say Coxsackie virus. But let me tell you, Coxsackie virus picking up is very rare, and generally I do not remember any case where you could actually.
It is very rare, and second thing is that it can be seen, adeno and Coxsackie can be seen in intestinal infections.
Intestinal infections also, so not necessarily.
Biopsy is actually considered to be
Yep.
as per indication. There is in 2019 and 20 they had a young myocarditis. There was a guideline where actually in this type of settings young patient with classic myocarditis, so biopsy has been upgraded basically to.
So, but what do you find in biopsy? So, for example,
Fulminant, especially they wanted to know fulminant or giant cell myocarditis. So viral.
So, one is giant cell myocarditis. Please listen, because this is like something which is very important. So, in biopsy you can pick up only actually three things. One of them is giant cell myocarditis.
Viral inclusion bodies of these things.
Viral inclusion bodies, this is the second thing, and there is another thing, third thing, which I will come later. But anyway, so I have left some food for thought, and we will gather tomorrow, and then we will try to see how this case progressed. So, thank you so much.